Tomorrow, on June 9th, over 200 sponsors and thousands of fatty liver disease patients, caregivers, and other stakeholders from around the world will come together online to celebrate the 5th International NASH Day. Surfing the NASH Tsunami is honored that the Global Liver Institute has invited us to create a preview episode to share with GLI and help anchor the end-of-day wrap-up session on Thursday.
For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 3, Episode 28 of Surfing the NASH Tsunami. Our preview of tomorrow's International NASH Day starts now. So it's been a momentous week for our panel. Louise celebrated the Jubilee. Jörn had Pentecost. Stephen tells us it's going to be 107 degrees in San Antonio today. And for those of you on the continent, that's 40. Yeah, that's 40. That's exactly 40. And I am feeling better after having wrestled with COVID for the last 2 weeks, but this is all the voice I've got. So if I get really creaky at one point, please forgive. I'm just going to quiet myself down. This is also the week of International NASH Day. That's tomorrow. Actually, depending upon when you're watching this, it might have started already because they are broadcasting their major sessions over and over again during the period. And in fact, after this, Jörn and Louise and I are heading over to John Donna and do the wrap-up panel at the end of the day, for which Jörn and I will put on ties. And I may even put on a jacket if it's cool enough in here for me to do that. With that, let me just say hi to everybody. Hey, Stephen, how you doing today? Glad you're with us.
Yes, doing well. Thank you.
Okay, good. Jörn?
I'm exceptionally well. It's a lovely Monday public holiday on this side of the world, and I just got done with a barbecue with the family.
Very nice. Very nice. And Louise?
Good evening, everybody. And I would have loved to have been at the barbecue. And Stephen's doing his deep-fried turkey.
Yeah, another week when we have a little more time, we will compare everybody else's barbecue recipes to see if anybody can get close to Stephen. I personally doubt it, but it's worth it. All right. With that icebreaker, one good thing that happened in the last week. I tipped a couple of things off, but you don't have to go there. Brave one, go first.
I'll jump in. Obviously, for us, we had a 4-day public holiday to celebrate the Queen's 70 years on the throne. So whether you love her or don't, it's a momentous occasion for any monarch, and it was a great celebration from the country. I started off in Stonehenge with the Druids for the lighting of the beacon, and I ended up in the Mall in front of Buckingham Palace for the ABBA group to finish off the concert. So it was a great occasion, and hats off to everybody who organised it, and it was a great day, and obviously many more years of Queen Elizabeth II's reign.
Louise, is she now the longest reigning monarch? Has she reigned Louis XIV from France? Do you know?
I don't know. I believe so, but I couldn't tell you on that. She's certainly the longest reigning British monarch. Queen Victoria was prior to that. Something in the female genes.
Yeah, she either tied it or beat it. I think, Louis XIV reigned for roughly 70 years and died of cellulitis, sepsis related to cellulitis from a leg infection.
Your depth of knowledge, Stephen, surprised me every time. I just looked it up. He reigned for 72 years, so a little bit to go, I guess.
Yeah, and she's rocking on.
A little bit to go. She's got to be 98 before she passes that mark.
Yeah, and her mother lived to 101, so hopefully she's got the genetics there.
Well, they say motivation is what keeps you alive, right? At that point. So she's got a record to beat, and then she's got a century pin, and then she's got her mother. So she's got attainable goals for the next 5 years. Excellent. Okay, who goes next?
Beyond having off the first day of the week, which is of course great, my last week was with travel a little bit, and I met colleagues even from the US, so that was great to exchange on professional topics around fatty liver disease. I'm very much excited and looking forward to NASH Day, of course.
Well, I don't have any earth-shattering news this week to bring to the table. Just gearing up for, I guess from my perspective, gearing up for EASL. I have a full slate of lectures to give there. So it usually between, what's today, the 6th of June. So the 18th of June, I board a flight to London. So 12 days to get everything in order is about par for the course. And so anyway, good times. Summer is in full swing in Texas. As you alluded to earlier, the temperature is 107. It should be. Global warming is here. Every day this week is in the high 100 single digits. So between 104 and 107 every day this week.
Will the famed Texas power grid hold up and all that?
You know, we've done a lot of work on that power grid, Roger. You know, we're cooking on all cylinders right now. We're ready to go.
Good.
Bring it.
Good. Hey, I'm rooting for you.
Stephen, you know, the good thing I was going to say, for you going to London, you don't have to record your talk 4 weeks earlier, because you would have been done by now, I think, with all your talks. You would have had to.
Yeah. Well, there's pluses and minuses to all that, right? You know, the stress of getting it recorded beforehand and trying to get all the data lined up, and versus kind of the beauty of giving it live is I could even modify it the night before if I need to. So, you know, but I would much rather give it live. I would much rather, you know, be in front of an audience where we can have interactive dialogue. I can take the questions in person. It's just so much better. And what I miss the most is after you give the lecture, all the people that come up and ask questions following that. They didn't want to ask in front of a big audience. And that's where a lot of, you know, people I meet for the first time, you know, many colleagues I've met over the years I've met that way, where the first conversation is one that happens after a talk, and you become lifelong friends and even develop programs together and that sort of thing. So looking forward to it. I know you're doing a lot of work there as well, Jörn, so I see you're all over the place.
Well, I'll be looking forward to see you then.
We shall all be there, and we are all looking forward to it. Good news for me this week. Well, the diabetes first episode goes up tomorrow night. This episode goes up Wednesday night, and we are posting a special Thursday night episode, which is that after this, Jörn and Louise and I are jumping over and doing a section of International NASH Day, and we will be posting that as a bonus episode of Surfing NASH on Thursday night. So in a week where normally we put out one thing during the week, we're putting out 3 on successive days. I've told Mike Wilson he's entitled to a gold tape for getting all this stuff edited. And I think that's my excitement, that and the fact that I got most of my voice back. So with that, why don't we go on? It seems to me that increasingly, if there's a holiday for NASH, it is International NASH Day. I think Global Liver Institute has done a really good job of making it a thing in its own right, and an important thing. So in the sense that at the end of the year, it always makes sense to look back and say, okay, what's happened over the past year? I thought what the 4 of us would do today, given that this is the band, is each of us take one thing, one theme, for what's happened over the past year that you think is of value or important, and run with it. 3 to 5 minutes, ideally, on opening statement, and then comments and questions, and then we will go next. And Stephen, why don't you kick us off?
Sure. I mean, I was thinking this morning a bit about the theme for today's podcast and what's different over the past year, what's changed, how have we advanced the field, and there's so many areas that in a lot of ways there's so many things that I can look at to say is different today compared to a year ago, but in so many other ways I feel like we're still in the genesis of a new galaxy forming. You can't really make out the solar system yet. You can't make out all the the planets and the moons. It's just kind of looks like a bunch of stars packed together. But when you drill down on it a little bit, I think where we've made some real granular progress is in drug development and understanding two things there. Number one, endpoint assessment, and I'll talk about that in a minute. And then number two, the design of late-stage clinical trials. And I'd like to start there because, I don't think we've changed our early phase 2A or even 2B trials that much over the past year. 2A, we're still accepting a non-invasive endpoint to generate safety and tolerability data and some early proof of concept efficacy data. We can build on that in phase 2B. We're still doing paired liver biopsy studies of 200 to 300 patients usually, multiple doses, placebo-controlled, and we're incorporating non-invasive tests, but again, primary endpoint, generally histology, and generally it's still NASH resolution or one-stage improvement in fibrosis. However, I think recently there's been a pretty significant change in the way that we're approaching phase 3 clinical trials in NASH, and that is maybe worth expanding on. And so if you think back to beta-cholic acid and elafibranor, so the Regenerate trial, the Resolve It trial, even early on the studies with Gilead, the idea being there that you enroll your phase 3 registrational trial in two parts. First part is 1,000 to 1,200 patients. That gets you subpart H approval. There's a finite histology endpoint at 1 year or year and a half. But those patients don't stop. You keep following them for a period of 4 to 7 years, and really you're looking for an outcome. And these are predefined outcomes, and you're looking for a certain number of them relative to placebo. So after you get your subpart H, you still enroll another 800 to 1,000 patients. So your total cohort size is somewhere around 2,000 or just north of that. And again, these are F2-3 patients you're following to an outcome. And beta-cholic acid is a great example of that. They read out their initial subpart H approval and close to 1,000 patients, presented that data. They saw 11% treatment effect delta in fibrosis. They then filed a new drug application. They awaited for the PDUFA date, and they received a complete response letter. They never stopped enrolling the trial. The trial still enrolled. It reached 2,000 patients or so, and many more patients have reached that subpart H biopsy, and then many more have continued. In fact, many patients have made it past the 4-year time point, I believe, in follow-up. Elafibranor was doing the same thing with Resolve It. Unfortunately, they didn't meet their statistical significance on their primary endpoint with subpart H, so that study was halted. Now, fast forward to 2022, and you hear the announcement from Madrigal that after meeting with the FDA, there's been a bit of a pivot. So now, instead of enrolling one trial to get subpart H and then extending enrollment to gather long-term data on progression to an endpoint, there are now 2 parallel phase 3s. There's the phase 3, which is enrolling NASH F2-3 patients. That gets you subpart H approval. It's a 1-year biopsy with a dual primary. So you either have NASH resolution without worsening of fibrosis, or fibrosis improvement by at least one stage without worsening of NASH. And there will be a yes-no decision based on a p-value of whether or not it looks like that drug might be approved, a new drug application potentially filed if there is that hope, there is a positive p-value, and then we wait for the FDA. But the new part of this is starting a well-compensated cirrhotic study that is considered a phase 3 trial, where you enroll patients for the sole purpose of an outcome. And the idea being you enroll 700 to 800 of these patients with well-compensated F4 disease to placebo or drug, and you follow them over a 2 to 3 year period, again looking for pre-specified endpoints. And when you reach that pre-specified number of events, the study's over. There are two things that make that attractive, and I think potentially change the game a little bit, or change the way that we look at enrolling these trials. We're potentially able to get to an outcome quicker, because we're not waiting for an F2 or an F3 patient to march to progression to cirrhosis, which is the most common outcome. We're not waiting for them to develop ascites, overt hepatic encephalopathy, variceal bleeding, MELD score greater than 15, death, or liver transplant. We're waiting for a cirrhotic population to get there. So the idea being you can get there quicker. But there's another benefit. We don't have to enroll more patients that have F2-3 disease beyond that subpart H approvable cohort. So you can essentially save on your enrollment in that subpart H approvable endpoint. You still have to enroll your 900,000 patients or whatnot, maybe more than that. But you don't have to enroll 2,000 in that cohort and then wait forever for somebody to progress. You get your subpart H endpoint at the same time you're enrolling patients in a well-comp F4 trial. We talked about this last year, but really it took a lot of effort in meeting with the FDA and partnering with the regulatory authorities to come up with this approach. And it's good to see that now that is about to launch. And so when you do that, the other benefit to a trial like that is you have increased alpha spend. There's an ability now to take, instead of NASH resolution without worsening of fibrosis, now you can bring up fibrosis improvement without worsening of NASH. It's not a co-primary. You don't have to hit both. It's a dual primary. It's an either or situation. And you have extra alpha spend because of the way that both trials are designed. So that, I think, is one of the major things I've seen happen this year. And I know I went over my 3 to 5 minutes there, Roger, but I do want to spend a brief moment on endpoint assessment, because I think that is something that's still evolving, but it seems to be picking up steam. We have a regulatory body who by all accounts is receptive to this notion of looking at modifying endpoints, and we're rapidly generating non-invasive data to help us address that. But in the intervening period, we're looking at ways to redefine our histology a bit, and that's really been pushed forward quickly because of the seminal work that one of the AI digital pathology companies did in connection with a large group of pathologists and hepatologists, and specifically I'm talking about the Journal of Hepatology paper led by Beth Brunt and Quentin Anstey, showing the difficulty in identifying ballooned hepatocytes. And I think that's really catapulted everybody forward towards looking to something that that we could use as an alternative for Subpart H approval. And so I don't have the answer today on what that is, but I can just tell you there is a lot of movement to crystallize that assessment, this new endpoint. We don't know what that is yet, but I'm going to hearken back to the trial design I just mentioned. And that is, at least from my foxhole, from my perspective, the ability to study well-compensated F4 patients is going to, I think, allow us to develop a non-invasive testing endpoint strategy in non-cirrhotics much quicker. And why do I say that? Because we have the ability, I think, in this F4 population to enroll a percentage of patients non-invasively without a liver biopsy confirming NASH cirrhosis. Remember, this is an endpoint assessment, not a repeat liver biopsy assessment. So if we could enroll people non-invasively, let's say they have an MRE greater than 5, we know that's cirrhosis, and we don't need a biopsy then, because we're looking at an endpoint. Did they develop ascites? Did they develop MELD score greater than 15? Did they develop decompensation, otherwise a transplant or death? And that'll also help us understand how the non-invasive test behaves relative to that endpoint, right? So if you have an MRE of 5 and that patient, those groups of people with MREs of 5 to 6 progress to an endpoint over 2 to 3 years at this rate of speed, versus you enroll an MRE of 7 or an MRE of 8 at baseline and they progress at X rate of speed or Y rate of speed, you can begin to understand more about how an NIT links to an outcome. And once you show that in a well-comp F4 population, I think we're going to have the ability to then take that data learned back to the F2-3 population.
That was incredible, rich summary, Stephen. Thanks for that. What resonates with me is that you highlight the point that NASH is a disease continuum. We started off studying it in the early or advanced disease population, pre-cirrhotic disease population in any case, and that is linked to outcome. And by introducing the second study, you kind of leap jump 3 or 5 years in that natural history of the patient group and just enroll patients that have already gone there. It's not a different patient group. It's the same patients. They've progressed down the line. It's not a linear progression, we know, if you talk about the fibrosis burden. So time course can be variable. But I fully agree that this is a very smart way to look at the patients down the road and dissect this or disconnect these difficulties we had from, a slowly progressive disease to the endpoints we want to study. So I think for that, these companies that are going this way are really helping us on the way forward.
Jörn's right. It's not linear. We want to know where we're going with patients. We want to know how we can assess them. And I think we are moving to a time when we're going to have to use in the real world when these medications come up. And I think doing trials in those formats ticks most of those boxes, which is really quite nice, because we're going to be able to implement that type of that trial program into real world care. And I think that's the strength of what you're describing there from my perspective.
So, Stephen, I was thinking of another great Mississippian, William Faulkner, as I was listening to you. And Faulkner's novels had all these different threads in the beginning, and in the end, they all came together. I've been thinking about the best episodes on this podcast, the ones that get the most listen and the most response, either tend to be conferences or other news events, FDA meetings or something, or they tend to be papers that galvanize interest. And an extraordinary number of those are all in the story, are all in this statement you just made, right? The complex hepatocyte issue episode did really well. When Lena Allen comes on and talks about MRE, it does really well. The episode you did with, I think, Arun last year about is Sanyal, about is cirrhosis the way to do drug development, did really well. And what's so exceptional is that each of those things was a piece. And through the work that you're talking about, they all blend together and it winds up coming out as a tapestry, which is... I've never thought of clinical trials a work of art, but that's frighteningly close to what I think I'm hearing. Certainly a work of craft. I was just amazed.
Well, I mean, I think there's so many major contributors to that tapestry, or another way to say it is mosaic. You know, it's just, it's amazing how we are really beginning to come together and work alongside each other to address these questions. You know, I think we're breaking down stovepipes, we're breaking down barriers, we're aligning. You take the NAFLD-MAFLD discussion as something that is a good analogy. I mean, we are in the middle of a Delphi process to address the right name for this. Should we change the name? If so, what should it be? And there will be like unprecedented international dialogue in July where we go through the Delphi process, we unpack it, we have a discussion about it, and we move forward on a unified front. At least that's my hope. And I think we're seeing that in the drug development space. Quentin was on with us, 2 weeks ago, I guess, talking about monitoring therapeutic effect of drug using NITs and really beginning to tease apart novel ways to look at that using, how long has that NIT been down versus relative to the length of time they were on treatment, and looking at stacked NITs, combining things like drop in ALT with drop in PDFF, change in FIB4, change in FibroScan. Is one NIT change just as good as two concurrent change, or three? Is that better than two, which is better than one? If you drop ALT by 17 units in the first 4 weeks, is that better than waiting until week 36 to drop ALT by 17 units, or does it not really matter? I mean, I think in a lot of ways, 2-3 years ago, we wouldn't be having these brainstorm discussions and looking at how we can combine data and work in a unified fashion to address these, find new questions, address those, and advance the field. And I think this is where we're seeing linear growth, Jörn. We're seeing almost just year after year, the number of publications in NASH that are coming out, it's unfathomable how we've just really focused on this area, and the data that's coming out, it's hard to keep up with. I mean, Jörn, this is all I do for a living is fatty liver disease, and I can't keep up with it.
There you go. I think one important thing, Stephen, is that we're, and I'm reminded by the episode we had with Quentin, is that we need to define the minimum required set of NITs. If you run an HCV trial, nobody would not think about doing HCV RNA. But if you run a NASH trial, people start using different markers and technology. So I think I don't see that clearly yet. And you mentioned that the optimal endpoint, or maybe there's still ongoing debate on what we're going to read out if we leave certain readouts behind. So I think that's the most critical next step to actually agree as a field. And the way the international consortia, but also, for example, NAIL NIT are looking at this is really, we're going to get this done very soon and define that set of minimal required NITs.
Yeah, that's another great example of where finally, 2022, we have become like-minded in the sense that we want to share data. We want to mine it for what we can get out of it. And Jörn, you and I have discussed this for the past 5, if not 10 years, how come we can't pool data together and use the power of data to drive the field forward? Everybody's been stovepiped. You can't look at my data. We're not going to combine it with this data. And now we begin to see that that's happening. So whether it's Nail and IT, it's Litmus, it's Nimble, it's all of it, I think is huge. And then you throw in International NASH Day and where that was when was it started? 4 years ago, 5 years ago? I can't even remember. And it advanced it to where we are today. And it's almost like, to use the surfing the NASH tsunami, it's almost a tsunami of information that's being provided to patients. And you see huge inroads made by GLI and the Fatty Liver Foundation and others, where patient awareness is beginning to grow. And I think it's all going to culminate. We have 2 potential drugs that are in play for potential FDA approval in 2023. One is a beta-cholic acid, still trying to get across the finish line, and then resmetirom, a thyroid hormone receptor beta drug. So, if we could get to 2023 and have 1 or 2 of those drugs approved, the groundswell of education that's happening, the knowledge that's growing amongst our constituents in the field, the providers, and then also on Capitol Hill and those that help us there and around the world. I think there's so much that's happened in the past year, but from my foxhole, the changes we've seen in drug development are going to be pivotal in helping us with future drug development.
Now, following up with what Stephen says, I think the most impressive moments or aspects that happened from my perspective in this year kind of follow up the same line. There have been great conferences and meetings where people got together to discuss how is the field evolving. It started out with NASH-TAG, where the regulators actually came to sit down, that fireside chat with clinical researchers to start thinking about the redefinition of those endpoints. And the other meeting we just had recently in Barcelona to pull together all these stakeholders, including nurses, primary care, and endocrinologists, to say, what are we going to need to identify these patients, and what are we going to do once we have a drug? How are we going to treat or follow them up? And I think this discussion that wouldn't have been thought of 2 or 3 years ago. We're really advancing to the point where we're ready fit for clinical practice, and we got to think about how to implement these changes in everyday life. It's something, if you sit in a specialty clinic, Stephen says he's doing this for his living. I have a little bit more diversity in my clinical duties, but there is a lot of patients still. The only I can offer them is enrolling them into clinical trials, or helping them to the next treadmill or nutritionist. And I think this is going to change very soon, and I feel a lot of momentum in the field on that level.
So the idea of momentum in the field is interesting, right? I mean, momentum among the people in the NASH-TAG meeting is one thing, but then getting some excitement out into the broader community is I think, huge. I also think when you talk about that, I also think of things like the ACE guidelines. The idea being that other societies have started to put more messaging out there. The American Heart Association paper, AGA, that more societies have started to put more out there about why this matters. So Jeff Lazarus, the first time he came on, said hepatology can't do this alone. But now I'm not sure hepatology has to do it alone entirely. And I think that reflects energy back on hepatology from the other sources as well. It's an interesting dynamic, I think.
Yeah, it's not physicians that have to do it themselves. And, one thing I wrapped my head around was the NASH nurse we're talking about, and, something that Louise can maybe follow up on, of course. But we need assistant or supportive disciplines here to really help us tackle this.
I think you're right. I think what we're now looking at is more of a conversation with and dialogue with other specialities, but we're also recognising what strengths we've got from within. We've got a lot of very skilled hepatologists, nurse practitioners, and liver nurses that we can use that strength to educate and help the patient populations, also guide into trials, also deliver the medication when they come. And I think that strength has grown, certainly over the last 2 years specifically, and I think maybe COVID has helped that, and that we can't do it all on our own. And I agree. I think only hepatology has to deal with fibrosis. We only use tools predominantly that look at fibrosis, because those are the ones that we want to get who are going to have the liver outcomes. We now have toys like FibroScan that involve fat. Fat for me is far more informative than necessarily the fibrosis is if you've got a normal KPA. And I think I talked the other week about Escoptic's new device. We're seeing more and more devices and non-invasives coming into the forum where you can detect liver fat. And I think the strength of that is endocrinology, cardiology. Those are the risk factors further upstream. And I think if you'd have told us 20, 30 years ago that we would have a device, or any device, that you could just place on the liver, MRE, put them in a scanning machine that would change the ballpark of what we know about liver disease to help a clinician in the clinic, you wouldn't have known, we'd have just laughed. But these things have developed. So where we're going in the next 3 or 4 years is very exciting because of the speed of that development. And I think, alluding to what Stephen was saying, we've got so many more people now in the field of fatty liver disease because a lot of people have moved from hepatitis C. We put the army of liver specialists behind hepatitis C, and that worked really well. Now we're doing the army behind the NASH and NAFL populations, and I think we're starting to reap the rewards on that.
So, Stephen, do you have a thought, or should we let Louise go on to her meta idea, her bigger idea? Or maybe that is a bigger idea, but go ahead.
Well, I mean, I cannot say anything that Louise needs to say her piece, because she usually has lots of very important things to tell us. So I would love to hear what she has to say first.
No pressure then.
So, Stephen, I should tell you that my comment, my comment last week about military guys acting without bravery, Mike decided to cut that out and not make the episode. He'll do that to this one too. But if you try it a third time, I swear we'll get it. We'll get it in. I promise you, the third time will be the charm. Go ahead, Louise.
No, I was very much going to focus on non-invasive techniques moving forward, and then I thought, well, actually, we've had the non-invasive therapies that we've got now for a while. It's about mining the strength of those therapies, and yes, we were discussing that with Quentin a few weeks back on the sequential use of those assessments. I think AI reading biopsies, I've heard a lot more now about at liver conferences, even from the Global NASH Summit that was the other week, histopathologists saying we need to do better, but we're not going anywhere, but we want assessments that can help us read better. And so that for me is a key part. But I think the actual coordination now that Jörn was alluding to of multidisciplinary agencies in trying to attack a multidisciplinary disease and a multifactorial disease. So that for me has been the strength. And what is key to me about this is we are doing it ahead of when we've got drugs available for distribution. Where normally the last things that go in is the care pathway to deliver an outcome and a method to get the medication out. By bringing it this far forward, we will have a real opportunity to deliver medications to the people who need them most in a really timely manner. And GLI lead that. If you look at GLI's NASH conference last year, I think it was about 170 partners. This year it's over 200, I believe. So each year that global movement is speeding up and we're getting more attraction. So, and I think coming on back onto Jörn's and Jeff's conference, the earlier we have these conversations with endocrine and cardiology, the better strength we will be. But we still need endocrine and cardiology to accept that we deliver a lot of care to their patients, and their patients are a lot of our patients. Nobody can own them. We need to share every single one to give the patient-centric care. So I think that for me is the strength. And we will have more discussions with nurses in the NAFL conferences in the future, because that's the strength that we've got. It is well utilised currently, but it could be utilised better. That conversation has to be had in local levels, particularly in low and socioeconomic countries where it's the nurse that will take on a vast majority of that local community work and dialogue. And that's where the changes can happen, particularly in diet, exercise and quality of diet that we're now learning a lot more about. So I suppose for me it's bringing it back full circle from the trials to distribution at the end.
The way you look at this, Louise, is interesting because, of course, you've gone through the era of treating hepatitis C, not knowing where the patients are. I think we're in a much better position in terms of, as you said, predefining those patient care pathways and identifying the right patients. So we're now in the, at the starting block, ready, just waiting for the gun to sound and kick off the race and see when the first drugs come to market. I like that.
Yeah, and I think we've done a better job of learning from our past experiences, but we're doing it in a much bigger disease state, right? With hepatitis C, maybe we didn't do a great job of pre-identifying the patients at greatest risk. Well, in fatty liver disease, it's such a much bigger pool, a much bigger sea of patients, and finding those that need to be treated are even more challenging. And so getting ahead of that before we have the first regulatory approved therapy to treat the disease has absolutely been very, very fun to see and watch unfold. And I think that will continue to crescendo, right? I mean, if we're, as I mentioned too earlier, we're targeting late next year, for drug approval, it seems like that's not very long away, right? I mean, you're 5 quarters away from being there. The work that we've done so far, the work that all of us have done in trying to grow this awareness is only going to continue to build. So I can't wait to see where we are, 6 months from now, 9 months from now, a year from now, as we lead up to something potentially very big. So the coordination of care is huge. The sequential use of non-invasive tests is huge. Thinking about combination therapies now that we're getting some better understanding of the pathogenesis of the disease, and we're beginning to see the first fruits of the labors of these drugs coming across in late stage phase 2 trials. I think it's all kind of coming together. I can't wait to see a year from now what we're talking about relative to this. Roger, if you were to write this down, a year from now on June 6, 2023, a couple days before International NASH Day, where we've come relative to what we talked about today, I think we will all be blown away.
Stephen, I'm going to ask us to do that at the end, actually. So you got to get ready. And I completely agree with you. I don't think they say that the reason it's so hard to write fiction is that fiction is stranger than truth, right? So somehow we've got to find a way to get out past what we know into those kinds of things. I agree with you completely. I do want to make one comment as a pharma industry past pharma industry person. Hep C is really unique in that the time span from the first agent that people got a little excited about, which I'm going to say was pegylated interferons, to when Gilead launched Harvoni and Sovaldi was 7 years, maybe 6, maybe 8, but something in that range. in cholesterol, to get from the first cholesterol drug to the first really good statin was 35. In blood pressure, it was 25. In cancer, it was longer than that. So one of the reasons that people weren't ready for it is that the market didn't have the time to do that kind of development. And the other here, of course, this is such a target-rich environment. If 25% of the population has the disease, then if you throw a stone, you're going to hit somebody with fatty liver disease, which wasn't just true of Hep C. But it's a difference. Other thoughts, or should I go on? Okay. All right. Okay, so we get three of my favorite themes into the same conversation here, which is the law of unintended consequences, convergence, and complexity. And this isn't all about obeticholic acid getting a complete response letter, but that really did change the tone in a couple of ways. First of all, unintended consequences. Everybody feared when the complete response letter came that might be the end of NASH. No one was going to put any money in. We weren't going to learn anything. All this momentum was going to go to waste, blah, 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 blah. Obviously, that didn't happen. What happened instead was that people had to be more thoughtful and serious about the questions they were asking. So it stopped being, how do I get a one-level improvement in fibrosis? And what in this thing isn't making sense? And so the first big what in this thing isn't making sense question was the Davison paper, right? And the idea that code of reliability didn't exist when you were grading fibrosis, right? So one of the reasons, and at the same time that happened, instead of trying to figure out how does everybody fit a therapy around an FXR backbone, people started asking what's going to be the most efficient way to deliver therapies over time, which is how you get to care continuums and combination therapies and different drugs at different points and all that. So this field really wound up having the freedom to develop its thought patterns unanchored from a different sense, tsunami of billions of dollars supporting a single point of view. You know, all that money didn't show up 3 years ago. And what's happened in the interim is that people have had to, working with the budgets that they had, work together, think smarter, think more convergently, and go back to basic patterns. And what we're seeing now is, I think, remarkably exciting. The point I was going to make is that the energy coming out of NASH Tag this year and the panel with FDA and everything that's ensued from that, every time I talk to folks here, 2 years ago, people were really, gee, is anything ever going to happen here? Are we ever going to get a drug, blah, blah. Now, the optimism, the positive energy that goes one way or another, this thing is going to work out, is consistent. It's the drumbeat I hear in every conversation I have. And to those, starting with Stephen, who were relentless optimists when people couldn't figure out why there was a reason to be quite so optimistic, my hat's off to you, my friend, because not everybody saw the path. Not everybody either saw the path or believed you had to keep going anyway. And to those of you who did, you, Rohit, a bunch of others, that's what set the stage for where we are now. And yeah, I think in 2023, we can't imagine what we're going to see in a year. Oh, and Don also,
well, I think
GLI.
It all comes down to what we see every day in clinic. You know, Jörn, Louise, what we see is people that are begging for something to help them. They're presenting with decompensated liver disease. They're presenting with fatty liver, and somebody told them for decades not to worry about it. Lose weight and exercise, it's not a big deal. And yet we know it is a big deal in a lot of our patients. And if they have cirrhosis, it certainly is a big deal, and the patients know it's a big deal. You know, so when you see that day in and day out, as a healthcare provider, we're torn. Our heartstrings are pulled. We have to figure out something to help our patients. And while many benefit from lifestyle change and weight loss, and some benefit from bariatric surgery, the vast numbers of our patients we see need something more. And I mean, just look at everything that we've studied. I mean, my gosh, we were we've been throwing statins, diabetic medicine. We've tried to, anything that was FDA approved for another indication that we thought might move the needle, we've looked at. Orlistat, vitamin E, vitamin C, combinations of both those. Every SGLT2 inhibitors, GLP-1s, and we see positive results coming out of the GLP-1 field. But who we are as providers won't tolerate no as an answer. We won't tolerate it can't be done as an answer. There's no hill too steep or river too wide to cross. I mean, we have to do it. And I think what we're seeing now is a little success begets more success. It begets more until we are all riding this wave of energy, and this momentum is just building. It's like a snowball rolling downhill. You can't stop it once it starts, and it just builds and builds and builds. And that breakthrough is imminent. It's coming. And whether it's a breakthrough in drugs, a breakthrough in non-invasives, a breakthrough in our endpoint assessment, a breakthrough in disease awareness and public knowledge, a breakthrough in regulators, a breakthrough with legislators, it's all going to happen. It's just a matter of time.
Roger, let me just say something very quickly in my own and more simple German English words here, I guess, because I had the same thoughts running today. I heard colleagues say, what are you going to do if this trial fails, the phase 3 fails, and you don't get a drug approved? This disease is not going to go away. I see compensated cirrhotics developing cancer, passing at an early age. We have to do something, and we're doing something. And as such, even with a negative trial result, this field has developed with a momentum that this will be brought to a finish line.
Amen. I completely agree. Completely agree. So with that, we're going to go to Stephen's closing question. We're not going to write it down, but we're going to have transcripts, Stephen. So we're going to open the transcripts in a year, and we're going to see what the four of us said today. Tell me the big idea 1 year from now.
So let me go first, or was that an invite to Stephen? I'll say something because the first is always the easiest, and they never hit the target anyways. I think in 1 year we're going to have a metabolic drug with a positive endpoint and an effect size leading to NASH resolution in a subset of patients. And we're going to start discussing how we could combine this with a drug that's very soon down the line to support weight loss and showing NASH resolution. And as such, I think we'll have the discussions around, is it worth to combine two drugs, different MOAs leading to NASH resolution, and what's the importance, or what's happening to fibrosis in that context? So I think there will be a lot of the drug development discussions ongoing.
I'm going to come from a different angle on that. I'm going to come from the fact that what I'd like to certainly see is that we have comorbidity nurses, somebody sitting in cardiology who's assessing their patient generally. They're all using non-invasive tools, FIB4 or FibroScan become more usual. And that's happening in an endocrine clinic, a cardio clinic, and hepatology clinics. But it should be happening in primary care. So I'd like to see that strength developed, because unless we invest and develop that strength, we will not find the patients who we will start to turn around on those interventions alone, and we can measure those outcomes. But the ones who will need the medication when they become available, hopefully 2023, if not early 2024. But if we don't start that conversation now and that funding now, we will be behind the curve. We'll have medication and no way to get it out. And often the funding for the structures is the last thing that comes online.
My big, fat, hairy, audacious predictions for where we are 1 year from now. Number one, we're going to have more drug failures. It's going to happen. And people think of that as a negative, but as Jörn said, the failures that we've had so far have only galvanized the industry, galvanized our resolve to work harder, and identify a drug that's effective. And I think that's what we're going to see more of. There will be more failures, but there will be successes. And these few successes are going to leapfrog the drug development for our patients. I think also we'll see the results of the first combination therapies really synergizing the field. So in other words, in the past, we've put drug A with drug B, and we try to look for ways in which the two drugs did better. But really, they didn't do much better. I think we'll see in the next year drug combinations where we're blown away with the synergistic effects, not just on histopathology, but on glycemic control, on weight loss, on liver fat content reduction, and on atherogenic lipids, all of it, renal disease included. And I think you will not slow down the train of disease awareness. That has left the station, and it's want to pick up steam. As Louise mentioned, the number of people that are on board with International NASH Day compared to last year the growth is palpable. It's easy to see. And if you compare this year with last year, with the year before and the year before that, it's significantly more and more. And I think we'll see even more next year. So that's where I think we'll be.
That's great. And so I'm going to go to a different place. I'm going to talk about money, because the real challenge here is going to happen when all this hits payers who are not known to invest, right? Who like expenses that fit into quarterly or annual budgets. And a lot of what we're talking about here is long term. I believe this disease has the potential to be uniquely successful with payers for a metabolic disease, because insurers, whether they're public or private, need patients, because patients are voters and patients are employees. And if the disease awareness train does not slow down, and in fact speeds up, as Stephen says, then the smart people out in front of it will mobilize the patient energy to turn patients into voters and employers who say this has to be dealt with. Too many people are going to die. Too many of us are going to be impaired. And I think if it plays out right, not that it will be immediate, payers take time, but that we will see more and faster movement from payers than we have in similar situations in the past, or than people are expecting we are going to right now. And that would really be, the last piece. At that point, we've completely shifted the playing field. So, with that, Stephen, Jörn, Louise, thanks. What a great discussion, and what a great way to lead into International NASH Day, giving people things to think about, and as they listen to the panels that will follow. And we will be back next week with a preview of EASL, and look forward to seeing you then. So until then, everybody, thanks. Everybody say goodbye.
Hey, we have to end on a Ted Lasso quote, since I'm looking at Louise, and it's all about soccer in the UK. And that is, you don't bring an umbrella to a brainstorm. You know, hey. That's what we just had here, was a brainstorm. Yeah?
Yes, now I get it, I think.
There you go.
So here's my closing Ted Lasso quote. Believe.
Believe. Oh yeah, but you got to angle it. You know, it can't be just perfectly.
Stephen, if this hasn't been the tilted angle for belief, I don't know what is.
That's true.
Yeah, no? Okay, that's everybody true. Say goodbye.
Goodbye.
All right.
And I'll be back in a little bit with business.
Barbecue. Jörn's made me hungry.
Okay.
I had mine already. Enjoy, Stephen. I'll see you guys next week.
See you next week. Bye-bye now.
Please join hepatology researchers and key opinion leaders Professor Jörn Schattenberg and Dr. Stephen Harrison liver wellness advocate Louise Campbell, and pricing and forecasting guru Roger Green, as they take stock of the most significant changes in fatty liver disease since the last International NASH Day, right now, on a special video episode of Surfing the NASH Tsunami.